Welcome everyone to CGD. We are delighted to have you all join us for this event on decentralized purchasing of essential medicines, what we know, what progress has been achieved, what does evidence tell us, and what could be implementation strategies and policy actions related to this. My name is Prashant Yadav. I'm a senior fellow here at the Center for Global Development. This event is being live streamed. If you have questions, there will be time for questions at the end. Make sure you send your questions through Twitter, email, or through the YouTube link, and we'll get to your questions. We have ample time reserved for that. I want to start by reminding everyone of the work that CGD has been doing in the area of global health procurement. The Future of Global Health Procurement Working Group a few years ago highlighted what can be the way procurement for essential medicines be organized in the future so that it fits within a larger agenda of universal health coverage, health financing, and so on. But one item that we keep going back and forth on in policy discussions is how should the distribution of essential medicines be organized? If you get the benefits of better pricing, better quality supply selection from procurement, that doesn't necessarily guarantee higher availability of medicines at the health facility level. We all know that efforts led by donors and other global agencies and national governments in improving the supply chain through the government channel using central medical stores or autonomous government agencies, they have not yielded sustainable improvements over time. They have worked and improved the supply chains for HIV/AIDS, TB, malaria, sexual and reproductive health medicines. But when it comes to essential medicines which are purchased with domestic financing, we have not seen such sustainable improvements in availability at the health facility level. So one idea that we keep hearing from multiple colleagues, national governments, subnational agencies is what if health facilities were allowed to purchase directly from suppliers? And the evidence on this is mixed. And so what we did at CGD was to collect and synthesize evidence on this, which is what we'll start today's session by presenting that. This was joint work with Mila Nepomniachtchi. And but the way our session is organized is as follows. So we are going to start with a 10-minute presentation by Mila, which will share the findings of our review. We'll then go to Ishani Kanpal from the World Bank, who will share some additional findings on direct facility financing and how it impacts availability and other health outcome metrics. We'll then have a panel discussion. I will introduce each of the speakers as we get to that section. But before that, let me just highlight the fact that we have a blog and a paper which has just been released, which is the summary of our synthesis of evidence that's available on this. So we encourage you to all have a look. If you have questions, comments, either during this event, after this event, we'll love to hear back from you. So with that, I want to move to the next step, which is a presentation of our key findings so far. And this was joint work with Mila Nepomniachtchi. Mila currently is at the Center for Innovation, Introduction, and Acceleration at USAID. This work was done by her in her independent capacity before starting her current role. She has rich experience in market shaping for health commodities at multiple organizations, CHAP, but she's also worked in the private sector and brings a wealth of knowledge both about analytics on health markets, but also strong field experience of how things work in LMICs. So Mila, welcome to CGD, and the floor is yours. 10 minutes of presentation to brief our audience on what our findings are. Thank you.
Thank you, Prashant. It's a real honor to be with you today and take part in this distinguished panel, so appreciate it. So I'm going to just share my screen. make sure this works. Can you see in presentation mode? Let me just do switch. Is it showing correctly? Yeah. Okay, so I'm going to start by just clarifying some of the scope that we had when we undertook this research. So we really focused on lower level health facilities. And by that, we're referring to facilities that are right below the tertiary and secondary hospital levels. So this includes primary health facilities, dispensaries, health centers, et cetera. And we really focused on commodities that were not funded by donor funding. So commodities that were predominantly funded by government resources or out-of-pocket payments. And when we think about what we mean by essential medicines, we're really referring to medicines for those under 5, for expecting mothers, for existing mothers, for increasingly for older people as well who have non-communicable diseases. So for most of those medications, out-of-pocket payment is by far the main financing channel. And we prioritized evidence that looked at situations where lower level health facilities purchase directly. So where they have full autonomy over where they get their medicines from. I'm going to start with presenting an analytical framework that we used as we investigated the literature. So if we look at two main functions of medicine procurement and distribution, there are 9 micro steps that we identified. So one is a process that identifies suppliers and products. And the second is a process that ensures that those commodities actually get to the facility on time and that they are indeed the commodities that were ordered and paid for. What we did was we asked ourselves, what is the current role of lower level health facilities in these phases? And so currently, in most places, health facilities play some role in forecasting. Typically, it's in a consolidated fashion, so they will share their needs up to a district or regional level, and that gets fed up to a central level. And in many cases, they also place orders, so through a pull or a push mechanism. And again, that tends to be consolidated and fed up into a central level. Facilities have much less of a role when it comes to product selection, price negotiation, and contracting, purchasing, and contract performance management. And it's these 4 areas that we hypothesized might be ripe for more facility ownership. And we wanted to see what the evidence on that would be in our research. When we looked into this, so we actually investigated 5 common medicine supply operating models against this framework. And on the right here, you can see 5 of them listed. The first one is the most centralized and one of the more common in low and middle income countries. So the idea of a central medical store that's really run by the government, and all of these phases are run through a central government system. And at the number 5 there is facilities purchasing directly. So facilities deciding pretty much all of this. Ideally, they are informed by essential medicine guidelines, standard treatment guidelines and such, but actually in many cases, facilities do choose to purchase medicines based on their local context, which is arguably a good thing. And then we have a variety of operating models in between that our paper discusses in more detail. So what did we find? The published evidence is limited. When we approached this work, we had about 15 country leads and country case studies that we hoped would give us some evidence that looked at price, quality, and availability. But unfortunately, that didn't quite pan out. So our paper covers a number of different examples, but at the end of the day, we really have only 6. With some amount of rigor that we can say definitively that we found evidence on one or more of these outcomes. And you can see on the left, so Cameroon and Nigeria have pretty good experience with performance-based and direct facility-based financing pilots. And so where there were strong evaluations on those programs, there was a deep dive on the role of facilities actually purchasing their own medicines and just having much more autonomy around medicine procurement and distribution. And so there is very favorable quantitative evidence that availability has actually increased in those cases. Moving to the right, we have examples of health systems that just have this in their routine health system operations, and so it's not so much a pilot or experiment, but this is how it is. And in the literature that covers these health systems, we have some indication that at least some qualitative evidence that at least there's a favorable outcome, certainly on availability. And we have reason to believe that the outcomes are strong also as it relates to price and quality, because in most of these systems, particularly in the US and Ghana, there are interventions at the government level to regulate price quality as well. All the way to the right is Tanzania, where there's a very rich history from 2011 of introducing various models that really focus on giving facilities more autonomy. And so starting from 2011, there was a pay for performance scheme, and then a few different prime vendor models that were introduced. And there is both qualitative literature as well as quantitative evidence that these schemes have actually worked. It's worth mentioning that for each of these countries in the report, we go into a fair amount of detail on how on how the operations actually worked and what it takes to do this. We have a stakeholder analysis that outlines what the responsibility is of different stakeholders in the health system for the 9 steps that I referred to earlier. But the question remains then, what does it take? And I think this is some of the findings from the report that I'm excited to get feedback on today. Ultimately, I mean, the bottom line is here, there is evidence that this can work, and medicine availability has been known to be greater in places where lower level facilities have had more autonomy and can purchase more directly. So the policy implications, this is a very high level summary. I'll flag a few things. Just going back to the hypothesis I mentioned in the beginning, when we look at the 4 steps that we hypothesized health facilities can play a greater role, where we landed was that they can do more when it comes to purchasing and contract management. It does seem that more centralized approaches to product selection and price negotiation and contracting can have can make more sense. And even there, again, I mean, to be more responsive to local needs, it makes sense for health facilities to have some flexibility when it comes to product selection, but certainly they can do more when it comes to purchasing and contract management. And I will flag that the contract management step in that framework I referred to earlier is probably the weakest when it comes to available literature and evidence, and needs to be more looked into, because that is really the crux of accountability in the whole system. If the medicines don't show up when they needed to, that's when something has to change, and that's what that role does. We identified a set of prerequisite conditions for both the public and the private sector. And we go into much more detail in the report, but I'd just like to highlight for the public sector, predictability of demand, of volumes, as well as of processes, and transparency on processes is very, very important in order for the private sector to respond accordingly. Where there is a lack of trust between the public and the private sector, then this is unlikely to work. And to highlight in the private sector, the key theme here is a vibrant distributor network that has to be in place in order for products to actually get to where they need to go. There are many risks to the system. We've provided 8 here in order of relative importance, although we also offer some ways of overcoming these risks. So none of them are really insurmountable, we argue in the report. Probably the most important one would be limited resource capacity, but I would like to flag again that this is already happening. So in most places, health facilities at the lowest levels are already figuring out their own solution to medicine procurement where they can do that. And they're doing it either with patient funds, with government funds. So it's happening. And I think the question is there room for more stewardship to make sure that quality, price, and availability aren't compromised? So just a few final thoughts here. One, reliance on pre-vetted vendors can be a good thing. The United States is a good example of a health system. Well, there's two actually. There's one run by the Veterans Affairs and one through the Department of Defense that was mentioned earlier, but these are both parallel health systems in the US. And this model has worked for many years. It hasn't really changed. But it has worked, and a similar model has been introduced in Tanzania with positive results. So it's possible to do. And a core component of those models are enforceable framework agreements that really go into detail on what's expected from both sides, and enable a great deal of flexibility and agility in the system. Secondly, this type of system could actually strengthen the government-funded supply chain, because arguably that supply chain could accommodate a smaller number of commodities that they're directly responsible for. And so the issues as they relate to risk and burden of work, et cetera, can be more spread out. And finally, we have seen, particularly with evidence from the performance-based financing work and direct facility financing work, that the act of giving health facilities more autonomy can actually strengthen them in many other ways, such as improved public financial management capacity. It can also drive increased quality of local suppliers because there's more levels of oversight. So there are many positive externalities to the system. So I will leave you with these thoughts here at the bottom in blue. Firstly, essential medicine availability is a cornerstone of universal health coverage. This is extremely relevant and important as we move forward, and it's happening. And so ideas that can balance the economies of scale that come with central price negotiation and supplier selection, that can balance that with the responsibility and agility of decentralized ordering need to explore more systematically, but not doing anything about this should be off the table. So I look forward to everyone's inputs and reflections on this work and encourage you to read the paper for further detail. Thank you.
Thank you, Mila. That was crisp and very precise, and gets out at least the core findings from our work in this. And like Mila said, much more detail is available in the paper, which we just put out earlier today. One thing that you would have seen that stands out in our work on this in synthesizing evidence is that the results are mixed. You know, we can't say with a great degree of certainty that facilities purchasing directly is improving availability or has no negative impact on price or quality. But given that supply chain changes and transformation is a complex intervention, it is not something which is a very elegant single intervention. And therefore, every time we look for evidence on whether it is working, what impact it's having, it's harder, and the likelihood of getting mixed results is always high. So I think in our work, we try to look at why, how, under what circumstances, what are the prerequisites, more with the idea to inform an implementation strategy and to put out potential risks when a policymaker or national government is thinking about decentralized purchasing at the health facility level. So that's the tone in the paper that you will see across. But Mila mentioned performance-based financing, direct facility financing. So it'll be very interesting to hear from Ishani Kantpal. Ishani is a senior economist in the Development Economics Research Group at the World Bank, has worked quite a bit on generating evidence related to cash transfers, women's empowerment, and health service provision. So Ishani will share with us some findings from the World Bank's work on PBF and direct facility financing, and also try to bring out where that points to evidence on availability, increase, no effect, and so on. And that'll set us up for a good discussion afterwards as to, do we have sufficient evidence? What is it telling us? So Ishani, over to you. Ishani, you're muted.
Yes, I know. Sorry, I was having trouble unmuting myself there. Okay, thank you so much, Prashant, and thanks for the kind introduction. Let me start my timer. Okay, so today, as Prashant mentioned, I'm going to summarize some evidence from a couple of different contexts from World Bank funded pilots that were both on performance-based financing, but I think both speak to things that might be of interest to us here today. And these are from Nigeria and the Kyrgyz Republic. So just to sort of fix expectations, a word in the big picture. So, you know, a lot of low-income countries have had now for some time, for a few decades perhaps, improving primary health service utilization, but at the same time, stagnant health outcomes, which suggests that quality of care and not just the simple utilization of care is a central challenge to improving health outcomes in these settings. And so often in this space, performance pay or more broadly speaking, performance like linked financing is proposed to address this conundrum of improving service utilization but stagnant health outcomes. The question then arises though is whether the constraints to quality actually lie within the locus of control of the health facility or the health worker that is receiving the performance pay. Because if it doesn't, if those constraints lie outside the locus of control of these units, the facility or the worker, then you know, performance pay has limits to what it can do. And in fact, if there are lots of constraints that relate to infrastructure, to drug availability, to supply chain issues, then in fact, there may even be a quality of care argument for something like direct facility financing rather than performance pay, at least as a starting step. So in some work with Gil Shapira, Jeanette Waldorf, and Pablo Fernandez, we just did sort of a benchmarking exercise trying to understand where the capacity constraints lie using data from 5 sub-Saharan African countries. So these are the Democratic Republic of Congo, Nigeria, Cameroon, Central African Republic, and the Republic of Congo. And what we find is that in all 5 of these countries, this is for basic antenatal care, these are primary health services, primary health centers that are supposed to provide antenatal care as part of their routinely provided services. Yet for all of them, there are pervasive capacity constraints for basic infrastructure, for basic drugs and supplies and consumables availability. So things like, you know, a scale, measuring tape, things like that, in general, we see relatively high levels of availability, but even there, you know, for something like the DRC, the obstetrics stethoscope is only available in about 77% of the facilities that we visited. But things like consumables in particular for diagnostic testing, HIV tests, syphilis tests, urine tests, these things are much less available. And these, of course, are tied to the provision of high impact aspects of a basic antenatal care visit, right? So beyond just taking a pregnant woman's height or weight, it's important to, for example, in HIV prevalent areas to be testing her, you know, whether to start PMTCT or not, or, you know, even doing a urine test to screen for proteinuria, but often these facilities just don't have the consumables they need to do that. At the same time, we find that there are also what the literature calls no-do gaps or idle capacity. So that is, you know, care that the providers have everything they need to provide, including all the knowledge, but they still don't. And we do find that there are no-do gaps that exist for all aspects of care, of what the WHO protocol says is necessary for a complete antenatal care visit. And yet that's, you know, compared to the levels of structural capacity, often quite low. And so, you know, that suggests that, again, idle capacity is only one aspect of the problem when it comes to the provision of high quality care. The structural capacity might be just as big of a deal in many of these settings. So in Nigeria, which is the first one that I'm going to talk about, in fact, if you look at physical and knowledge constraints, which are here in purple and yellow, for many aspects, particularly for testing, it's the physical capacity rather than the no-do gap, which is in red, that dominates as sort of the binding constraint, the provision of those aspects of care. So in these sorts of settings, in primary healthcare settings in much of sub-Saharan Africa, public health facilities don't have an operating budget. The facilities, as Mila sort of summarized, receive a set of drugs and services intermittently that's based on their size and the services they're supposed to provide, the catchment area that they're supposed to serve. The staff salaries are paid directly by government. And so in this sort of context, if a piece of equipment breaks or if there's a stock out, there has to be a request that goes up to the centralized government agency, which might be at the district level, might be higher sometimes. And so, repairs or replenishing stockouts can take weeks or even months. So an open question here is whether simply decentralizing, simply sort of quote unquote, this in itself is not an easy intervention, but simply decentralizing health financing by providing operating expenses and allowing frontline facilities, if needed, to bypass the official procurement channel can be a pretty meaningful reform in this sort of setting. So the Nigerian pay for performance pilot is actually one that's in the paper by Prashant and Mila and others. Here we evaluated this three-state pilot. So there was in Nasarawa, Ondo, and Adamawa. It had two arms that were treatment and one business as usual. So the first one had performance-based financing, and the second had this decentralized or direct facility financing, DFF. The PBF and DFF arms were identical in that they both received facility level autonomy for primary health centers. They both received enhanced supervision. They received operational support, and they received payments that were in the PBF facilities based on the delivery of these predefined services that were provided by each facility. In the DFF arm, these payments were actually not linked to any sort of performance. So they were just unconditional grants, if you will. By design, the PBF payments were additional to the operational support that the facilities received. So in effect, PBF disbursed twice as much as DFF. And I will say that the official procurement channels still remain centralized. And I'll come back to this very briefly at the end. Although what we know, and Mila sort of referred to this, about price and quality from our impact evaluation is limited, but I can conjecture. Nothing's ever stopped an economist from conjecturing, right? So just a quick word on what we find. These were published late last year, mid last year in BMC Medicine. Very little to choose between PBF and DFF in terms of service provision. The only difference is on institutional deliveries, which is largely led by an increase in institutional deliveries in publicly owned health facilities. Sometimes DFF actually ends up being more effective than PBF, and other times the differences are less significant. Even compared to business as usual, it's unclear what PBF is necessarily purchasing beyond the institutional delivery impact. So here's sort of a key table from the paper on the impact of PBF and DFF on the availability of tracer drugs and key consumables. So we look at here just a number of essential drugs from the standard list of 18, EPI vaccines, TB drugs, and test kits for malaria and HIV. Again, these three states are malaria endemic, so it is really important that they be screening pregnant women for malaria. We find a significant increase in both the PBF and DFF arms over and above control in the number of drugs that were available in the facility, number of those 18 drugs that were available on the day of the survey. And we find a smaller increase, but also significant, of PBF over and above DFF. That said, the most important thing to note is that the increase in both PBF and DFF relative to business as usual is substantial. So at baseline, actually 34% of the facilities at baseline didn't stock any of these 18 tracer drugs correctly, not expired, stored as they should be. And by end line, we're talking about a substantial increase, a doubling or more. Similar results are, we find similar results for insecticide-treated bed nets being in stock on the day of the survey, about half of the facilities going up from about 30%, and also an increase in the number of contraceptive methods in stock on the day of the survey. Okay, I want to touch very briefly on another context, which is the Kyrgyz pay for performance pilot. This is work that Jed Friedman and I did, and we evaluated this. We finished the evaluation, although we're still working on the paper, in 2020. This is a very different context here. We're talking about secondary hospitals who are generally well provisioned, but they do not have any autonomy over, or they did not prior to the P4P pilot, over their operating budgets. In that regard, they're similar to the Nigerian setting. There were 63 eligible district hospitals in the country, which we triplet matched and randomly assigned to one of three arms, so performance-based financing, which included enhanced supervision only, so there are actually no additional funds being dispersed to those facilities, and business as usual. The supervision visits happen quarterly using a balanced scorecard. And here procurement was much more decentralized as a result of the pilot. And we evaluated this for a similar time period, 2014 to 2017, as the Nigeria study. Here, what we find when we look at quality impacts, including process quality, is actually very similar impacts of PBF and enhanced supervision. Often there's no difference, or sometimes between the two arms, although there's sometimes a difference relative to business as usual. The only place where we find an incremental impact of PBF over enhanced supervision, again, remember that the enhanced supervision arm here doesn't actually get any financing, is for the availability of drugs. And so again, this is an index of tracer drugs for labor and delivery. At the same time, we can use the birth registry data from Kyrgyzstan to show that it was PBF and PBF only that led to improvements in maternal and neonatal outcomes. So we're talking about things like the volume of blood loss by the mother, the ABGAR score of the newborn. And we don't find these impacts for the supervision arm, suggesting that, to the extent that we see any differences in process quality or clinical quality between these two, they're really tied to the availability of drugs and services, and not sort of even, we use things like the Mama Natalie to assess clinical quality, no differences. So it's sort of suggestive that some of these gains at least appear to accrue through the supply chain effects, through the better availability of tracer drugs. And this highlights the role for direct financing, even in higher level facilities, even in relatively well-provisioned settings. And so to summarize, direct facility financing can be really meaningful where there are frontline facilities that typically don't have an operating budget under their control, which means that they're typically not able to respond to simple stockouts of essential drugs and supplies, and that constraints to quality might lie normally outside their locus of control. When we think of improvements, of interventions to improve quality of care, we think of things like performance pay, training, and management. But there is this very basic fact that sometimes facilities can respond to things like stockouts or equipment breakages in the absence of direct financing. And so there can be quality of care arguments to direct facility financing, right? So it's not just about service utilization or service provision, but it's actually related to the quality of even clinical care that we can observe. That said, as Mila sort of highlighted, neither of these studies really looked at the price or quality impacts. In Nigeria, we had still relatively centralized procurement, and so the additional procurement that happened was often through vendors that were not pre-vetted. And so we don't really know what happens there. There might have been negative impacts. Whereas in Kyrgyzstan, there were pre-vetted vendors. These are bigger hospitals. These tend to be in city centers. So anyway, that was the caveat that I wanted to end with. And with that, I'll wrap up. Thank you.
Thank you, Shani. Very interesting findings. We had seen the Nigeria data, but the Kyrgyz data is also very interesting and adds a new dimension, like you said. One is the ability to trace it to supply chain effects, and the second being even in slightly higher level facilities, and we'll go to Irene and talk about that in a minute. So, but one thing I want to bring up before we move to our discussions and panel discussions phase is, while in some of the data that Ishani presented, it included things such as bed nets and contraceptives and other donor-funded health products, the bulk of our discussion, and in particular of the synthesis paper that Mila and I put out, has been non-donor funded, national government financed and purchased or financed medicine. So while those benefits on donor-funded products are interesting to observe, our focus is not necessarily those items. So just to set the scope somewhat more well-defined. With that, we want to move to our panel discussion. We have, in addition to our two speakers, Mila and Nishani, we have three panelists. Lombe Kasonde from the World Bank, Africa region, sends her apologies. She cannot join because she's not been able to get back to a stable location and is on a field trip. But we have three very knowledgeable panelists who are going to join us. So let me start by introducing them very briefly first, and then we'll go to them for short 5-minute remarks. So first I have Dr. Boniface Funda Funda. Boni, as some of us call him, is the interim Chief Executive Officer of the Africa Resource Center for Supply Chain. Before his current role, Boni has been in a number of roles in government and also in international organizations. He was the chief executive of the Medical Stores Department, which is the Central Medical Store of Zambia. So he ran a public agency that purchases and distributes medicines. But he's also now been supporting multiple country governments to think about supply chain transformation projects of various types. So we'll come to Boni. The second panelist we have is Irene Veru. Irene is the Deputy Chief Pharmacist at the Kenyatta Hospital in Nairobi. She's a clinical pharmacist who has worked extensively in the design of protocols, in pharmacoeconomics, in a number of related activities. But one thing we thought would be very interesting to hear from Irene is, even for a tertiary hospital or almost a research and referral hospital, how challenging or easy is it to purchase directly from suppliers? What are the challenges that come up? So we'll go to Irene to discuss that. And last but not the least, we have Kelly Hamlin, who is a program officer at the Gates Foundation in the Global Delivery Program. She focuses on supply chain management there, very deeply embedded in work which is related to what we're discussing today. But before joining the Gates Foundation, Kelly has worked extensively in country supply chain for USAID in Tanzania and Rwanda. So one of the examples that you saw from the paper that Mila shared is the prime vendor system in Tanzania. So it'll also be interesting to learn from Kelly about some of the work in Tanzania and how that fits. So those are three panelists. The format is I'm going to give each of them 5 minutes to share their initial reactions on what you heard from Mila and Ishani and my little interludes in between, and where do you think the idea of decentralized purchasing, facilities being able to purchase directly, does it have merit? What are the risks? Are there other items that we may have missed that you want to flag to us? And also talking about implementation, is this an idea that is worth taking into implementation, or there are many other things to be done before that? So let me start with Boniface Funda Funda. Boni, over to you.
Thank you very much, Prash. I think maybe we can start off by asking the question, can it be done? And I think the evidence offered from presentations by Ishani and Miller is that there's evidence that these things can be done. The direct purchasing by hospitals can be done. I think the question next is, what do we need to have in place? What are the prerequisites itself, as well as to ensure that the funds are not going to be waylaid or be abused. I mean, there's a lot one even at central procurement when you look at misprocurements and all these other issues. So I think there's one can say there's a requirement to ensure that the background oversight work is actually in place. I mean, if you look at the private sector, first of all, we have so many private sector hospitals across Africa that comfortably do their own procurement and you hardly ever hear of stockouts and all those kind of challenges. So there's sort of precedence there that a hospital can procure medicines. I think for public institutions, it comes down to the policy to kind of provide them with that capability to procure. Even right now, you find that across our countries, you find the larger hospitals are favored with a certain budget to procure medicines. But then sometimes it's like only those special medicines that don't make sense to be procured by, say, the central medical stores, and it's only for, say, the specialized hospitals. In some cases, you've got provincial hospitals that are buying from the center and are acting as hubs for hospitals in their province, so the district hospitals can access the medicines from a provincial site. So this kind of arrangements are in there, but I think they are not obviously looking at providing capability to allow a hospital to go full scale to buy the complete list of their requirements at a hospital level. And yes, of course, we are talking about different levels of procurement in terms of numbers of medicines and other health products. A central hospital or a provincial hospital may have to buy over 200 products. A district may not have to do that. That's one thing. The other thing is the logistics of buying itself, whether the outlying districts or provincial hospitals will have to come to the center where there are the available suppliers, because most of these suppliers are not all over the country. But again, if you look at what the private sector hospitals are doing across most of these countries, they are able to arrange that capability to procure. So I think in terms of ability, these arrangements can be put in place. Central planning, central contracting, central negotiations for prices can help a lot. And I think, therefore, when you have investment to say, let's make sure that then the appropriate hospitals can do procurement, then we have to invest in creating that capability. Once we have done the most heavy lifting, which can be done at the center. So I think then we need to invest in the prerequisites, as I said, such as ensuring that there's appropriate procurement oversight, across the many hospitals that may have to be buying medicines. We also have to invest in ensuring that there's appropriate ability to manage funds across these health facilities. I don't think you want to leave it to individuals to try to manage that and be the controllers themselves. And I think you also want to make sure that the regulatory affairs for medicines is also fairly strong across the country, so that as people are buying, they're following the rules and regulations for buying safe and quality medicines. So I think these prerequisites should be considered as part of a policy framework that can help make a decision about enabling the health facilities to do direct purchasing. To simply rely on the current structures, which is to say, Hospital X has got 15% of its operating budget to be able to buy medicines just in case a hospital, medical source rather, has run out of medicine. That may not necessarily be good enough. So we may have to say, how do we ensure that these big hospitals, for example, can work with the center to be able to buy medicines themselves? What sort of budget should they have? And what are the controls to put in place to make sure that they're able to do that? And then maybe as the practice becomes much more secure and we can demonstrate compliance across all these regulatory requirements, then you can begin to create capacity across the provinces up to the district. And hopefully industry becomes interested to be able to say we can provide and supply to all the hospitals across the country. So I think for me, these are the prerequisites that need to be considered, rather than simply say, let's create the ability to buy, because we can do it. As I said, private sectors are able to buy. So I would say that's maybe there's something to consider. Thanks very much.
Thank you, Bonnie. I think while most of your comments were geared towards hospitals, I'm going to extend that and say hospitals and, let's say, larger health clinics, because some of the structural issues that you described are similar, such as if you are located in a somewhat rural and remote region, the supplier deliver to you, would you have to come to a major city or the capital city to actually purchase? That has additional logistical elements and so on. So I think But one part that you reminded us, in addition to several things on prerequisites, such as regulatory capacity and so on, is the private market ready to serve if health facilities start purchasing directly? Will they have to buy from a retail pharmacy in their town or little other smaller wholesalers, or would major wholesalers and distributors start reaching them? And this is another active area which we didn't delve deeply into in this paper, but a lot of new digital innovators have come in. A lot of new social innovators have come into this with new business models. They are doing consignment inventory, vendor managed inventory, and their ability to get product out to health facilities is increasing. So in a way, we are at a cusp of, on one side, increasing ability of health facilities to purchase. On the other side, also the private market, especially fueled by these new innovators, which can hopefully get the product out to the geographies that were traditionally not served as well by larger private wholesalers and so on. So that's an interesting cusp of two things coming together. We'll get into that in a minute. Let me go to, because you brought up hospitals, it's also a very natural segue now to go to Irene. Irene, at a large hospital in Nairobi, where, so firstly, tell us how you think about getting supplies from a public agency, a public supply agency versus purchasing directly from suppliers, and what kind of challenges come when you're thinking about purchasing directly from suppliers at the Kenyatta hospital. And if you were to then put yourself into the shoes of a smaller hospital or a clinic, do you foresee that happening in a similar way as it is happening at Kenyatta? What kind of challenges do you foresee? Can we imagine a system in which larger hospital pharmacists start acting as mentors or as advisors to smaller health clinics, so that if they need help, you can help them out on, I got the prices from this supplier, I selected this supplier, etc. So, and also, I think much of our discussion so far has focused on essential medicines, and we've not precisely defined that, but I think you also do a lot of work on NCD medicines and oncology. So we'd also love to hear from you. Is there even suppliers in the market who can supply NCD medicines and oncology? So over to you, Irene. Irene is, like I said earlier, the Deputy Chief Pharmacist at Kenyatta Hospital in Nairobi. Thank you.
Thank you, Prashant, for your question. Many questions, thank you. At Kenyatta Hospital, one of the things that has helped us is that the finances for essential medicines and all medicines in general is actually ring-fenced. So every year when we do our budget or when we do our midterm expenditure framework, we have our finances for pharmaceuticals actually separated from the rest of the budget. So that means that we have autonomy, and that helps us to do our own independent procurement. The pharmacists in the hospital are largely involved, one in quantification and product selection. So that, I think, has worked really well as a benefit. And even as we start this discussion, it is one of the things that we can actually provide mentorship and guidance for the smaller health facilities in terms of evidence-based selection and quantification, and just making justifications for budgets that are adequate for the products that they need to procure. On the question of our experience in terms of procuring from the central stores, which is in our case, Kenya Essential Medicine, Kenya Medical Supplies Authority, compared to procuring from independent suppliers, is that from the independent suppliers, we are able to get the quantities we need, and to a large extent within the timelines that we actually have set in place. The Kenya Supplies Authority, the way they supply medicine, sometimes we see delays, and many times we've not had the quantities that we actually would be requesting for. So, and then of course, there's the issue of payments that sometimes, especially when we need to do drawdowns for UHC, the finances are not coming directly from the national hospital, they are coming from the central government. And sometimes if there's a back and forth between the central stores and the national government that is outside of our own institution, that can cause delays that are outside our scope. And we may not be able to intervene, but we still will experience the delays that impact on our supply chain in the hospital. So the way we procured from the independent suppliers is such that we do our own tendering processes, and that is really tedious. So when I think about our procurement process, that many from the tendering specifications, developing that, and then going into advertising for the tenders and doing the tender evaluations, that is really a tedious process, and the smaller facilities may actually not be able to do the same because they may not have the capacity in terms of training and the staffing that they require to do that tedious procurement process. So that can be a bit difficult for them, but then that is where the bigger institutions like Kenyatta Hospital and other referral facilities would come in, because then the smaller facilities would be able to draw from the experience of the bigger facilities, and maybe instead of doing the complete tendering process, they can do direct procurement based on the experience that the larger institutions already have and the reasons for selection. In Kenya, what really helps us is that we have the regulatory framework is in place. We have the Public Procurement and Disposal Act that is actually in place and implemented, and at the National Referral Hospital, Kenyatta National Hospital, that is what we adhere to. So in terms of selection and the entire tendering process, including identification of the suppliers and the different steps in procurement, that is what really guides us. So if we have the smaller facilities actually going by the law, that would be easy for them to implement. Some of the challenges that currently our smaller facilities are facing is that they procure small quantities, and so they are not able to get the price benefit of that we have as the national hospital, because we buy in large volumes. And that's not just for the essential medicines, but also for other NCD medicines, including oncology commodities that are not on the Kenya essential medicine list. We are able to have better prices because we have bigger volumes. The smaller facilities, sometimes when they go directly to the retail market, they get the prices, they get the products at double the price or even more than double the price. You had asked earlier, I think when you were asking Boniface about the bigger suppliers going into smaller towns, that sometimes is not possible because the cost of transportation would again be transferred to the institutions or to the county government, and that will mean that the price of the product goes even higher. So most of the time, if a product is missing from a facility and it's not in the central stores, you find that the smaller facilities would go to the retailers or to the smaller wholesalers in their vicinity, and not necessarily to the bigger, well-established wholesalers who are able to give them better prices. So of course, these many middlemen mean that the prices go up. So that's a big challenge that we find the smaller facilities facing. But in conclusion, I think there's opportunity for the bigger facilities to actually provide supervision and guidance, and even just training for the smaller facilities so that they can learn from our experiences. And then the last comment I would have is that we have also within our institution a robust pharmacovigilance system in place. We have a whole unit that deals with pharmacovigilance and medication safety. So that means if we have a product that is of questionable quality after we have gone through the tender process, because of course, you know, at the tendering process, most of the products will meet the minimum criteria. They will have acceptable samples. But even as you continue to use the product, if you notice something that is of questionable quality, we are actually able to take those products through a whole analysis process. We have funding set aside to be able to take products for analysis at the university or at the National Quality Control Lab. And that we are in control of. It's within our mandate as a facility. So that helps us. And the smaller facilities may not have the same resources. So that's why sometimes they'll say that the products they have, they are not very sure about the quality, and that becomes a challenge for them. But again, they can draw from the experience of the bigger facilities. One of the things we've done in the oncology pharmacies online groups is that people share experience. Like if you have a product that is of poor quality, then you ask around and other people are able to give you their experiences. And if a product is seen to not be of good quality, then the National Cancer Control Program will take it up with the Pharmacy and Poisons Board. So I think there's opportunity for us to interact at different levels, in different places. But again, like Boniface had said earlier, we need the legal and regulatory framework to be strong enough for us to be able to do that. And we need ring fencing of the funding for the facilities to be able to procure their own products. Thank you, and back to you, Prashant.
Thank you, Irene. Very insightful. So we need ring-fenced money, and this is where, what Ishami shared about direct facility financing doesn't necessarily make ring-fenced money available for medicines, right? Typically the money being given in direct facility financing is a lump sum, and it's up to the facility manager to decide what portion of that do they use for medicines, for other purposes, and so on. And in some cases, in fact, there are limits as to you cannot use more than 25% of the total money you get as DFF for buying product and so on. So your comment about ring-fence money that is aligned to what the needs are, that is important from the research and referral hospital all the way to the primary health center in case the primary health center is buying directly. So the role of financing, budget alignment, and so on. But the second interesting thing that you mentioned about more intermediaries come into the supply chain when you are trying to deliver to lower level facilities, especially that are in far-flung areas. That's once again an area where we are seeing a lot of new models come up which are trying to disintermediate the supply chain. So instead of the usual structure of the national importing wholesaler selling to another wholesaler who then sells to a sub-wholesaler who then sells to a retail pharmacist, and each one adds their markup, we are seeing the emergence of new business models that are going more directly from the importing level, sometimes actually directly from the manufacturer up to the points of sale. They are all fueled by both innovation and ingenuity in business models, but also new technology. So we also want to see, can that change in more meaningful ways than it already has? And your last point about people already are starting to share information about which product and which supplier is not necessarily of good quality, and having good pharmacovigilance systems is a helpful aid in that. So if I'm a small county hospital, or if I'm a county pharmacist, I can come to Kenyatta and say, I'm thinking of buying from this set of suppliers. This is the price I'm getting. Do you have any insights or information to share within the constraints of what public procurement law allows? That information sharing can enable some more of the concerns we have about supplier selection, quality, etc., under decentralized purchasing. So thank you again. Next, we want to go to Kelly Hamling. Kelly, like I said, is at the Gates Foundation. And Kelly, we want to hear two things from you. One is at the Gates Foundation, when you're thinking about procurement and distribution, decentralized procurement, and how does distribution get coupled with it? Are they distinct? Are they common? And what are your views on what we've shared in terms of the synthesis so far? You've given us comments and have collaborated with us on this paper as well. So one is that part, and the second is, for a moment, if you take off your Gates Foundation hat and go back to your role in Tanzania, where the prime vendor system, which has been very successful, at least for some period of time, came about, and also efforts by USAID and other agencies in improving the central medical store. How do you situate the two together? Are they either or? Are they and? How do you think about this in your mind? So over to you, Kelly.
Yeah, thanks, Prashant. And this has been such a great conversation. So really enjoying hearing the perspectives from this group. I think to your last question, what speaks to me is what we've been experiencing and hearing over the last 2 years and talking about supply chains is the importance of resiliency. And I think a critical point of supply chain resiliency is having a plan B and perhaps a plan C and a plan D. And so where I think there is a really strong argument for consolidated and pooled procurement at central medical stores because of the purchasing power that they bring and the ability to control for quality and bring prices down, there will always probably be a need for an alternative option or a recourse at a district or a network of clinics or at a facility level when the system breaks down. And the system, there is always times when the system would likely break down, and that isn't necessarily a failure of the system, because if we controlled for everything, it would be unwieldy. And I think that with that in mind, having as we've actually heard other panelists talk about, having a policy structure or a process in place for that backup plan for health facilities and clinics to have a recourse option is really critical. And that is not, it's the policy, it's the mandate to be able to take action when they need to, but that does not mean anything if they don't actually have the finances to actually operationalize that policy. And so it requires that the funds actually be there. And then I do think the third is, as we've already talked about, is the quality control process, the regulatory environment to ensure that when that does happen, when we are activating our plan B or our plan C, that it's within a price that is acceptable, that the quality of the product is high, and that we're getting what we are intending to and what we're paying for. So I think with all those three points, the other perspective that I would add is the importance of looking at that recourse option with a risk management lens as well. So it might mean, for example, that in order to activate that plan B, that the price will be a little bit higher. But that premium of getting something in short order from a local retail pharmacy, for example, is worth it to avoid the stock out of that product. And I think rather than it being a very black and white, we either do this or we don't, it's actually about, okay, well, let's talk about what our trade-offs are, and is, like, as we're setting this policy in place, is a slight increase in cost, or the additional cost in putting the quality control measures in place to have it there, and the level of effort to get it there, is that worth it to avoid the stock out of this product? And that's why I feel like having putting the ability and the power in place for a local actor at the health facility or the facility in charge to actually take action is really critical, because they would be able to do that risk assessment and be able to find out, okay, like, is this, to determine, is this worth it? Is this something that I need to take on for this additional cost, et cetera? I think the same goes for quality in terms of risk assessment. The quality control measures that we may put in place should be commensurate with what the risk is. So Tanzania, they implemented a lot quality control process where they would test a subset of the products that they were bringing in through their prime vendor model to ensure that that quality was there. That makes sense for them, perhaps in their it did make sense for them in their regulatory environment. In other structures, a framework contract might be sufficient, and then we would understand that we've pre-qualified these vendors and we have confidence that they would be there. So I think structuring what the policy and the process is according to what our risk tolerance is would really kind of add some enabling decision making. Thanks.
Thank you, Kelly. One caveat I want to add is that if Tanzania, which is a maturity level 3 regulator, requires the prime vendor to still do lot testing, then many other countries which don't have a maturity level 3 regulatory authority should have some kind of additional quality check. So while we can say that it's very contextual and circumstance driven, I think if Tanzania needed it, then a lot of countries in the LMIC income bracket would probably need some additional quality measure. One thing which has come out as we looked at this, as we discussed this, is that there is a trade-off. I mean, we have to accept it, that it's not, if it was simple and there was no trade-off involved, we would have seen much wider policy action in this. And the trade-off here is that there are economies of scale and scope in pooling, in centralizing a number of functions or steps, as Mila had described, and doing them centrally either at the national level or certainly at the provincial or state levels, for example, in Nigeria. That gets you the scale benefits, better prices, ability to have lower costs of doing quality assessment on a per unit basis, because you'll have a fixed cost that is over a larger volume base of products that you do quality testing on and so on. But you're trading this off against the responsiveness, the local feedback loops, the local accountability information sets that don't always travel back to the central planner in terms of what are the needs. And so we have to make a choice between this trade-off. And the reason I keep going back to there are new models evolving is we have to ask the question, are there new models, such as what we saw with the prime vendor, which essentially change the efficient frontier of this, right? Help us achieve both the economies of scale and the responsiveness of decentralized purchasing simultaneously by very carefully selecting which activities we do centrally, or finding a new type of entity that carries out some roles in which we have greater confidence. So that's one. And in this trade-off, Kelly added one additional element, which is the performance metrics that we've been looking at so far. What is the observed price? What is the quality? And what is the availability? Right? But in addition to average availability, we should perhaps also have a resilience metrics, which is saying, well, maybe average availability is not necessarily different between the two models, but which one of them fares better? Or what combination of these fares better when we want to add the performance metric of resilience to it. So that's what I'm taking away from what I've heard from all of you so far. We have a set of questions coming up in the chat, so I'm going to go to those questions. Most of them are not addressed to anybody in particular, so whoever wants to answer first. One is coming from Marsha Wolf, who's asking, how do you leverage entrepreneur-managed digital solutions to solve this issue? It seems like a partnership can be a wise way of addressing and creating the most efficient solution. So I think it's getting to this point I'm making about the new business models and digital and so on. So who wants to take that first?
If I can make an attempt at that.
Go ahead, Bonnie.
I think, yes, I think the new business models obviously include, supply systems and procurement arrangements that uses artificial intelligence or using digital systems anyway. But I think it still comes back to guarantees that need to be put in place to enable even that sort of kind of a strategy or approach to be applied. I think, like you mentioned earlier, something to do with, say, direct delivery from, say, a manufacturer who may be based in the capital city, or they may even be outside the country. And there can be arrangements to supply products all the way to the user site. But what needs to be put in place to ensure that those medicines are guaranteed in terms of safety, quality, and they meet the local regulations. So again, there's some background work that needs to be done to ensure that that sort of business can be performed with assurances. So again, it goes back to a bit of homework, which could be that you create pre-qualification arrangements for the sources that you're going to use as a district hospital, or as a provincial hospital, so that it's not just something that people sit in a procurement team and say, oh, let's press this button, or there's a supplier here who has got capability to use these tools to supply us products, or engage with us in order to reach a procurement arrangement. So I think it still comes back to having solid arrangements that recognize even the modern business strategies that are in place to ensure that they can be responsiveness, accountability by the district, and also the system can be resilient in terms of going forward. Over.
Yeah, thanks, Bonnie. Without spending more time on this, I just wanted to say to Marsha, who's asked this question, if you joined in and listening, Marsha, the Gates Foundation, USAID, CII team, many different subgroups within the World Bank, many others are starting to look very actively at what you're describing as the set of digital entrepreneur-led solutions to these problems. How do they fit into a larger framework? Does decentralized facility level purchasing enhance and enable them, or does it become a hindrance? Where do we stand on that? So very active area of work. So thank you for flagging that. The second question I want to bring up is what I heard come from Biel Pronk at MFA in the Netherlands. And Biel is asking, how would this impact equity and equality regarding access to medicine? So is there an equity component in this that we may be missing? Let me put that to Ishani, if you would, Ishani, and then we'll ask anybody else.
I was a little nervous that I would pull the short straw on that one. I think it's a really good question to ask. So in Nigeria, we do look at a little bit at sort of heterogeneous impacts of both the pay for performance and direct facility financing arms. And we do find that pay for performance actually, if anything, makes process quality a little bit better at facilities that were higher quality at baseline. And if you think about the facilities that tend to be high quality, they tend to be sort of closer to the city center. They tend to be serving slightly wealthier catchment areas. So that's generally speaking not great news for equity concerns. And even on that, if you remember the impact I showed you of institutional deliveries, of a PDF on institutional deliveries, some of that is coming from, much of that is coming from sort of the middle of the wealth distribution. So it's like, these are still sort of, rural areas. So these are not, wealthy households, but these are sort of the middle of the wealth distribution among rural areas in Nigeria who are benefiting from the improvements in quality of PBF facilities. So I don't know of a lot of direct evidence on the impact of decentralizing procurement, for instance. But I think based on what I know, I've seen enough to say that it's a real concern. There are ways to address it. So for example, my colleague Moritz Piatti at the World Bank is doing some work with a mobile money intervention, which is supposed to work with facilities. And this addresses many things, for example, that Bonnie talked about in terms of accountability, right? So you need to pair, even if you're decentralizing financing, you need to pair that with accountability. I think Irene mentioned sort of the timeliness of payments, and then also this ring fencing. You can build all of these things in, with mobile money, you can have a dashboard and you can say that you have to use at least this much for procurement of drugs. Anyway, which is to say, it's an important question. There are ways to address it. We don't have a lot of good evidence.
Thanks, Ishani. In the interest of time, sorry, Mila, in the interest of time, what I'm going to do is there are 3 other questions or comments. I'll just put them out. I don't think we have the time to answer them, but at least it'll provoke thought for everybody who's listening. One is coming from Lydia Zimmerman, who's asking, in addition to a central purchasing, can facilities self-organize themselves and say, we'll create a sort of a bulk purchasing pool of our own, and then go and get the benefits of economies of scale and scope that we talked about? So interesting idea, worth everybody thinking about. Jonathan Gunthorpe has 2 comments, and the one that I would like to highlight is that he's asking, is there an accountability role here? Can civil society, local civil society, national civil society, can they make sure that when local facilities are purchasing, there is some accountability mechanism? And I would say the answer is yes, but he's asking, Are there positive examples that we can find and highlight? We didn't put that in our paper, Jonathan, so thanks for highlighting. We'll do that. Okay, we have 1 minute left. What I want to do is the following. Ask each of you for one sentence and one sentence only, your ask for policymakers, and policymaker here is national government, health minister, people who run international development agencies. How should they think about what we've learned so far? I will start with Irene. Irene.
Okay, so my one ask would be for policymakers to involve pharmacy in terms of essential medicine supplies availability and to ring-fence funding for pharmaceuticals. Thank you.
Excellent. Thank you, Irene. Kelly Hamlin.
I think the critical component is getting sufficient funding for medicines where they need to be, where the decision maker is. Like, I think Ishani's point on having available medicine really kind of changed regardless of what the structure was. And so we should focus on that first. Okay. Mila.
Figure out a way to support primary care facilities and ensure that last mile delivery can happen and make sure there are accountability systems that support it.
Thank you. Bonnie.
I think to be open to innovations across the world, access to medicines and supply, procurement, etc. I think there's just so much that is happening that is possible to be applied within public sector. So if policymakers can be open to innovations, that would be quite constructive. Over.
Excellent. Ishani.
I basically repeat what Mila and Bonnie said, actually. So fund the front lines, make sure that they have ring-fenced funds, but also use new technologies to ensure accountability and quality.
Okay, thank you, everyone. This was fantastic. I learned a lot. Thank you, everybody, for joining, our panelists, our speakers, all of you who participated. This is just the start of a conversation on this. Keep your comments coming. Keep sending it to us. You know us, how to reach us. So don't be shy. Send us emails. If you want to critique, send us a war story of why this doesn't work, how difficult it has been. We would love to hear all of that. But once again, thank you to all of you, and thank you from CGD.